Good morning. Welcome to Mindray Live. Today, our topic will be focusing on safe anesthesia. The healthcare industry has put decades of efforts in reducing the mortality of anesthesia to a very low level. However, the challenges still exist. We need to take good care of our patients, from induction to maintenance and recovery. So how do we ensure safe apnea during intubation? And how do we maintain an accurate and stable anesthesia without causing post-pulmonary complications? Our first speaker, Gijsbert Stavast, Anesthesia Business Manager of Mindray Europe, will be introducing the mechanism and application of the automatic controlled anesthesia. Welcome, Gijsbert.
Hello, my name is Stavast and I'm the European Anesthesia Business Manager and would like to welcome you to this short introduction of the ACA function on the A9 new anesthesia platform at Mindray. Today we're going to talk about precise anesthesia and the practice today, how we do the anesthesia induction, for instance, the clinical assist tools which could help us with it, and the automatic controlled anesthesia. Precise anesthesia today is very important with the comorbidity and the elderly patients coming into the OR more and more. So this is one of the key features, as well as the safety for the patient and also the safety in the environment and also for the healthcare professional to have as less waste gas as possible. Now in today's practice, if you look at that, the anesthesiologist has to think about the target sevoflurane that he wants to use. The output, he has to adjust fresh gas flow rates. Then he has to wait for 10 minutes, for instance, then adjust everything. And then he does that several times during anesthesia. And to do so and to achieve all the targets that you want to have, like normal ventilation and have a stable anesthesia, there are some tools that Mindray has in this anesthesia platform that will help you with that. Now, the clinical assist tools, as we call them, the first one is the optimizer, and it will help you set the fresh gas flow enough to have a normal ventilation and oxygenation. And it tells you in the green area if everything's okay, set fine. If it's yellow, then you have a too high flow resulting in high waste gas. And if it's in the red area, then you have too low fresh gas flow. Also, the AA prediction tool for the anesthetic agent, it helps you in the decision-making of how to set your anesthetic agent. You have a trend vision of 10 minutes and 20 minutes in future. So you can see what happens if you're changing the output. And to do this, we need the anesthetic gas module with the O2 inside and electronic flow meter. And the third tool that we have is what you set is what you get. And that's what we're going to talk about today is the ACA function. So it will preset target of the FiO2 and the end tidal anesthetic agent will be done automatically. And herefore we need the anesthetic gas module with O2 measurement, electronic flow meter, and of course also an electronic vaporizer. So the anesthesiologist only has to set the required end tidal anesthetic agent and inspired oxygen concentration, and the machine will do the output and the fresh gas flow adjustment as needed. So the clinical benefit of the ACA is that we have a more stable anesthesia depth and oxygenation, and the time of the end tidal anesthetic agent concentration maintained in the desired range increased on 30%. Also, the agent use is decreased by 35 to 45% in the target control group. And there's less adjustment of fresh gas and vaporizer settings, and that will reduce the workload. And we saw that it reduced from 6.9 times to 1.6 times. The clinical benefit of controlled anesthesia, if you look at the cost effectiveness, we saw the consumption of nitrous oxide and sevoflurane were significantly less in the target controlled group. And also the time required to achieve the desired levels and the maximum inspired sevoflurane concentration achieved and the number of drug delivery adjustments were statistically significant in the target control group. Also, the cost of the inhalational anesthesia were reduced, and we saw also that the heart rate variability was very stable during this group. There was no big difference between the two groups. So if you look at the automatic controlled anesthesia flow chart, the entrance and setup, then we have the wash in and maintain and the wash out. So step one is touch the gas area on the display and select control mode ACA. The second step is to target the FiO2 settings, and the third one is to set the target for end-tidal anesthetic agent. Then acknowledge this. And on the display, you will see then on this settings. On top, you see the target end-tidal anesthetic agent concentration, and you see that 2.5% with sevoflurane. Then you see the usage speed, so the output of the sevoflurane vaporizer. You see the fresh gas flow used, the trend of the end-tidal anesthetic agent and of the FiO2. And then on the bottom, you see the set target for FiO2 and the flow rate, the minimal fresh gas flow rate. On minimal, that means that it will be as 300 mils per minute, and the machine will adjust itself accordingly with a higher flow if needed. You can also choose a fixed flow, but to have the control, of course, by the device itself will help you lessen the adjustments needed. So to wash out, we have two possibilities. One is to turn the vaporizer off, and the fresh gas flow keeps on auto control, so it will be automatically adjusted. And so you have the coasting out of the anesthetic agent. Now purging the vaporizer, turn off, and then to purge, we have different kinds of flows directly settable. So you can set it like 10 liters, and the flow will increase to purge the flow for faster washout. Now, the prerequisites to start up the ACA is that the system is working normally. So you have an anesthetic gas module installed, you have vaporizer working fine, and flow meters, of course. And the leakage test must have been passed and has to be less than 200 milliliters per minute. So from auto ventilation mode, and you go to the manual ventilation mode, you switch it over, the ACA will be paused, and the system and the fresh gas flow rate will have 2 liters per minute. Then the default of the O2 concentration and the anesthetic agent concentration will remain on the target. And as soon as you switch back from manual to auto ventilation, the ACA will automatically restart. As well as if you have a high FiO2 or low FiO2 alarm and a CO2 apnea alarm, also here the ACA will pause. The fresh gas flow rate now, in this case, will go up to 6 liters per minute, and also the default values of the O2 concentration and anesthetic agent concentration will remain the same. So if soon as the alarms are solved, then the ACA will automatically return. Also during refilling of the vaporizer during surgery, if you open up the lid, it will stop working, and then you can fill out. And as soon as the filling is done and you close the lid again, it will automatically restart the ACA. Also, if there are two different kinds of anesthetic agents detected in the system, the last non-targeted anesthetic agent will be washed out very rapidly until it's lower than 0.35 Mac. And then it turns on automatically the chosen new anesthetic agent and vaporizer and will restart the ACA function. There are also conditions where the ACA will go into the safety mode and doesn't start anymore. So that will be when the target is not achieved and the deviation is too big, so more than 15% of the target setting. And when there's a system malfunction, the anesthetic gas module is a failure, or gas supply, hardware, or the breathing circuit failure. And then it will go into the safety mode. So the fresh gas flow set will go to 6 liters per minute. The default value of the oxygen concentration and the targeted end-tidal anesthetic agent will equal the set targets. So the take-home message, the automatic controlled anesthesia gives you clinical tools for precise anesthesia with the optimizer, the anesthetic agent prediction, and automatic controlled anesthesia function. And automatic controlled anesthesia gives you more stable anesthesia depth and oxygenation. It reduces the agent consumption and greenhouse gas emission, and with less adjustment of the fresh gas and vaporizer, and therefore reduce the workload. I'd like to thank you for joining me in this short presentation, and I wish you a very pleasant stay further in the virtual ASA 2020. Thank you very much. Bye-bye.
Thank you, Gijsbert, for your inspiring sharing. High-flow nasal cannula is commonly used to help achieve apneic oxygenation during induction. Our second speaker today will be David Alonso Chacón, Clinical Marketing Manager for PMLS, Mindray Europe, and he will be introducing the HFNC oxygen in anesthesia.
Hello, and welcome to the Mindray virtual booth during Anesthesia 2020. My name is David Alonso, and I am the Clinical Marketing Manager for PMLS Mindray Europe. And on this short session, we will talk about the benefits and applications of high-flow nasal cannula oxygen delivery in anesthesia settings. So, if you follow me, we will have some background first. During surgery, there is a potential risk of being exposed to a prolonged apnea time, followed by an arterial hemoglobin desaturation. Pre-oxygenation using 100% oxygen before the anesthesia induction is highly recommended to delay the onset of arterial hemoglobin desaturation during this prolonged apnea time. We can have a look in some figures to understand the burden and the impact of this apnea time in anesthetic procedures. Based on a large retrospective study, including more than 95,000 electronic anesthesia records in France, 6.8% of patients presented hypoxemic events during surgery. The same study also showed that 3.5% of the patients presented a severe hypoxemic event of 2 consecutive minutes or longer during the surgery. Of those hypoxemic episodes, 70% occurred during either the induction or emergence phases of the anesthesia, which are actually 21% of the total intraoperative time. In another study that aimed to determine the incidence of adequate pre-oxygenation in a population sample of more than 1,000 patients in Canada, inadequate pre-oxygenation was observed in 56% of the cases. Besides of any perioperative hypoxemia events, difficult airway management is also an important issue that must be taken in consideration. The Difficult Airway Society defined difficult airway in 2015 as the inability to obtain effective ventilation after several attempts by an anesthesiologist with more than 5 years of clinical experience during mass ventilation or endotracheal intubation. We also can see some figures on this slide. Based on a study carried on more than 3,300 patients for elective surgery settings, failed intubation incidence is approximately 1 in 1,000 cases. A newer study carried in more than 7,700 subjects demonstrated that the failed intubation rate during rapid sequence induction was 1 in 300 cases. And a third study defined in Japan showed that in the ICU, emergency department, and pre-hospital settings, 1 in 100 intubations failed. So now we're going to move on into pre-oxygenation and denitrogenation to minimize risks in perioperative settings. The oxygen load during pre-oxygenation depends on several factors. Some of them are alveolar compartment, arterial compartment, tissue compartment, and venous compartment. but most of the oxygen is actually stored in the lungs as functional residual capacity. So the main goal of pre-oxygenation is to maximize the alveolar fraction of oxygen, which depends on the effective fraction of inspired oxygens, what we call FiO2. When most of the pulmonary nitrogen is replaced by the oxygen, the fraction of expired oxygen is increased to a value over 90%. Then we will know that we achieved an efficient pre-oxygenation. The most common technique to guide and achieve an efficient pre-oxygenation is to deliver 100% oxygen for 3 minutes using a standard breathing system to obtain an expired oxygen fraction above 90% as stated before. So we can say that the 3 main goals of pre-oxygenation and denitrogenation are: achieve 100% oxygen saturation before the anesthetic procedure, and denitrogenate the functional residual capacity of the lungs to maximize oxygen storage, to maximally oxygenate the bloodstream. So let's see now which are the main challenges of using conventional pre-oxygenation and how is that compared to the high-flow nasal cannula oxygen delivery. Conventional pre-oxygenation aims to achieve a pre-oxygenation status before an anesthetic procedure, but the delivered flow is limited to up to 15 liters per minute. That, added to the fact that the mixer with room air can decrease the alveoli FiO2, allows an apnea time of up to 6 to 8 minutes in adults. Using a high-flow nasal cannula allows a flow up to 60 liters per minute, and sometimes even higher, and a safe apnea time up to half an hour in adults. The high-flow nasal cannula uses to be presented as a standalone device or included in an advanced anesthesia workstation or ventilator. That allows the air to be humidified to increase patient comfort. Administering oxygen using a high-flow nasal cannula has 3 main physiological effects. The apneic oxygenation is achieved as the high oxygen flow removes the nitrogen and carbon dioxide accumulated in the lung. This procedure increases the pressure and gradient, allowing the oxygen to transfer to the alveoli much better. The positive airway pressure created by the high flow of gas increases the end expiratory lung volume and functional residual capacity. This is the PEEP effect. Also, this high flow promotes a reduction of the dead space by washing out the gases stored there, including those in the more distal airways. This is the dead space flush. So, which are the applications of using high-flow nasal cannula to administer oxygen in anesthesia settings? During anesthesia induction and intubation, the high-flow nasal cannula oxygen delivery could be very helpful to manage high-risk patients like the following ones. Obese patients with a reduced functional residual capacity and a higher incidence of atelectasis. In this group of patients, there is a case where ventilation and perfusion mismatches and leads to hypoxemia by shunting. Pre-oxygenation enhances the safety margin for induction of general anesthesia and the placement of the endotracheal tube. Also, pediatric patients show an onset of desaturation much quicker than adults, and also a smaller functional residual capacity with a greater metabolic demand. High-flow nasal cannula might prolong the safe apnea time in these patients and support on the management of a potential collapse of the airway. When it comes to obstetric patients, failed airway management during anesthesia procedures is associated with major sequelae for the mother and for the fetus. Therefore, effective and adequate pre-oxygenation is highly recommended. Also, the prolongation of the safe apnea time allows a smoother intubation process even when the airway is difficult to manage. It was also observed by Bettinger et al. That the use of high-flow nasal cannula oxygen for pre-oxygenation on high-risk patients undergoing awake fiber optic intubation minimizes the risk of hypoxemia, making the procedure safer. Continuous nasal oxygenation, low flow or high flow, is also part of the Difficult Airways Society guidelines for tracheal intubation in critically ill adults. Therefore, using the same principles, we already know that high-flow nasal cannula can also prolong the safe apnea time for tubeless anesthesia and maintain the patient airway for the optimal oxygenation and carbon dioxide removal, while the surgeon needs to access certain parts during the surgery of ear, nose, and throat. Also, during anesthesia recovery, the management of high-risk patients can be enhanced with the usage of high-flow oxygen, as well as avoid the risk of a potential reintubation. We hope that this session was interesting for you, and we want to thank you again to visit our virtual booth. Meanwhile, enjoy your Anesthesia 2020, and we hope that we will see you soon around.
Thank you, David, for sharing the knowledge. It is very interesting to learn about the applications of HFNC and how does it help with safe apnea. Thank you everybody for joining our live session today. Tomorrow at the same time, we will be having our next session talking about lung protective ventilation. We'll see you then. Thank you.